Okay, I'm now going to talk about other coronavirus outbreaks other than the common cold by way of background. And we've already mentioned these, but I want to go into a bit more detail about the two prior ones of SARS and MERS. Before I talk about them, I want to go into a digression which will be relevant to our discussion of SARS and MERS about the meaning of R0, which is often called the reproductive ratio, that describes essentially the intensity of secondary cases resulting from an individual who's infected. And then we'll talk about SARS as a case study and MERS as a case study. So to discuss SARS, or discuss R0 as a case study, I'd like to spend a few minutes playing this YouTube video. Okay. So the other point I want to emphasize, which was not covered in the lecture, is that the beta term is really a function of two individual other aspects. One aspect is the dose that's emitted by an infected individual. The other aspect is the intrinsic dose-response relationship for the pathogen. And we'll be talking more about both of these features in future classes. So the first one of the coronavirus examples I want to talk about is SARS, severe acute respiratory syndrome. And I'm going to excerpt a number of observations from this review article by Skłodowski, and I've also put a copy of this reprint on for the supplemental readings for this week. So they reviewed, after the fact, the case of SARS. So the emergence of SARS also occurred in southern China, Guangdong province, in November 2002. And then this was followed shortly thereafter by separate clusters of cases in different municipalities through mid-January. WHO became aware of the outbreak in February. At that point, there had been 305 affected persons, 5 of whom died, 30% healthcare workers. One of the issues with SARS is that the reporting out of China in the early days of the outbreak was a bit difficult, and there's a belief that a fair amount of the information was concealed. So as of February, there was an escape of cases from China, apparently due to traveling. A physician who had cared for patients in Guangdong stayed at a hotel in Hong Kong, and within 24 hours, he infected 16 other guests before being hospitalized. Those secondary cases then traveled further outbound from Hong Kong and seeded multi-country outbreaks through the spring of 2003, including Canada, Singapore, and the US. WHO issued a global alert on March 12, 2003, followed by a travel advisory, which, as shown here, were relatively rare and still remain rare. And as you know, that for the current SARS coronavirus 2, WHO never did issue a travel advisory. So when you look at the 2002-2003 outbreak, the biggest cluster, of course, was China, Hong Kong, and Singapore. But then by way of some traveling, there were clusters that were set off in Australia, although no local transmission followed from there. There were clusters that emerged in Brazil, and then clusters both in the US and Canada that did result in subsequent local transmission. Now, this curve is the epidemic curve, and essentially, this is the primary set of cases in China, followed by secondary and tertiary clusters in the other countries outbound from China. So in all, about 7,000 or 8,000 people were made ill with SARS. Now, it didn't become pandemic in the way that SARS-CoV-2 has been pandemic for several important reasons, and this points out the difference between SARS-1 and SARS-2. First of all, there was no transmission, no contagiousness during the pre-symptomatic phase of the illness. No evidence for the existence of an asymptomatic phase. And the incubation time was low. 4 to 5 days, range up to 10 days, which is 4 to 5 days shorter than the current SARS-CoV-2. R0 was computed by this group Chowell, as noted, in Toronto, Hong Kong, and Singapore. And the R0 values were all fairly low. The median estimates less than or just slightly greater than 1, with some variability with Hong Kong and Singapore being greater. And as the YouTube video showed, it's not surprising that the R0 values would differ between countries, because one of the aspects is the intensity of social contacts, which could very well have differed amongst the 3 locales. But in any event, the best estimate for the R0s were really just barely above, in the case of Hong Kong and Singapore, the levels needed to sustain an outbreak. Nonetheless, there were some interesting outbreaks, and some interesting factors emerged from them. The first one that I'll talk about in connection with SARS is Amoy Gardens. So Amoy Gardens is a high-rise apartment development in Hong Kong. And there was evidence there of secondary cases originating from a primary case. In this case, and each of those clusters is one of the buildings, there was a primary case in this building here, indicated by the red dot. Winds were blowing from the northeast, and there were cases in the other buildings, with these buildings suffering the brunt of it. And of course, a large number of cases in that building itself, building E, where the initial infected individual was. And so, can we explain this? Can we explain how the cases jumped first from the primary individual within the building to the other patients within his building, and then to the other buildings themselves? Well, studies using computational fluid dynamics and the prevailing wind direction looked at the flow between building E and the other buildings. And the modeling suggested that it was entirely reasonable for a plume to be emitted from building E, particularly to buildings C and D, that caused other cases. In addition, within that building, modeling was done of the ventilation system. The airflow, first of all, was estimated from the outside, and normalized concentrations were predicted in each one of the apartments on the floor plan. But as strikingly, there were people above and below the primary case who became infected. And both teams from WHO and from Hong Kong did investigation on site, and they essentially found that the floor drains of the lavatories in the units, which ordinarily would have a P-trap that's filled with water, were allowed to dry out. And thereby, they permitted the cross-connection between gases from the ventilation vertical riser to go from one unit to another. In addition, this happened when the exhaust fans were running. That created a negative pressure to draw air from the vertical stacks in. And so there were flaws in design and in operation. And the Hong Kong experts from University of Hong Kong concurred. And this, in fact, resulted both from airborne transport between buildings, but vent piping between lavatories. And of course, where did the contamination in the vent piping come from? From the toilets. Which indicates that, first of all, SARS, infected SARS-1 virions were excreted in the feces, and that aerosolization in the toilets going into the vent pipe could have resulted from the vertical stacks contaminating other units. I'll move from SARS to MERS now. MERS, Middle East Respiratory Syndrome, that remains the name for it, which is interesting in view of the controversy over SARS-2, that MERS is still the recognized name. MERS emerged first with reports in September 2012 from a patient in Saudi Arabia who was admitted to a hospital with pneumonia, having had an earlier kidney injury. Very shortly thereafter, a similar report emerged out of Qatar, an older patient also with a kidney injury, but who had traveled to Saudi Arabia and then traveled to UK. 2 cases from Jordan were diagnosed retrospectively, also as having MERS. Between then and 2013, when the outbreak subsided, over 1,500 cases of MERS were reported, with 544 deaths. So the death rate here is about 30%, which is much higher than SARS-1 or with SARS-2. In addition, there was an outbreak that occurred in South Korea in May and June 2015 that originated apparently also with an older person who had traveled to several countries in the Arabian Peninsula, returned to South Korea, and then transmitted MERS to other individuals in South Korea, many of whom were healthcare workers or family. Person-to-person transmission of MERS is rare. And the primary source of infection appears to be contact between susceptible individuals and camels, who were an intermediate host. In Korea, there was a significant cluster between healthcare workers and family, and first the initial patient and then subsequent patients who were not aware of the strong potential for contagion, and also because of particular characteristics in Korea of families staying within the hospital of patients to support their patient during their illness and recovery. So overall, the R0 for MERS is low, less than 1, but it's very, very dispersed, very, very heterogeneous, with the potential for some people to have high individual R0s and become super spreaders. So next week, we'll talk more about quantifying the source terms for coronavirus 2, evidence for different routes of exposure, decay rates, and overall exposure estimates. I'll be putting up quiz 1 this week, and please finish it by 11:59 p.m. Eastern Time on Friday. Have a good week.